Good afternoon, ladies and gentlemen. My name is Soomarat. I came from Faculty of Medicine, Rheumatology Hospital, Mahidol University. First of all, I would like to thank Pakistan Society for Rheumatology and APLA for inviting me to be speaker today. The topic I'm going to talk today is this juvenile idiopathic arthritis. The overview of my talk is JA classifications. I would like to share the case presentation with you and tips and learning points of each case. As we know that to diagnose juvenile idiopathic arthritis, the patient should have age less than 16 years and should have arthritis more than 6 weeks. And the most important one is the patient should be exclude other conditions, especially infection and malignancy before diagnosis. According to the ILA classification criteria, there are 7 subtypes of JA based on clinical manifestations. The first one is systemic JA, is the JA subtype that have systemic manifestation along with the arthritis. And if patient have less than 5 joint involvement, we call oligoarthritis. If patients have more than 5 joint involvement, we call polyarthritis, which include rheumatoid factor positive and negative. If the patients have enthesitis along with the arthritis, we call enthesitis-related arthritis or ERA. The ERA is quite similar to the ankylosing spondylitis in adult patients. So if the patient has psoriatic rash along with the arthritis, we call psoriatic arthritis. In some cases, patients can have arthritis along with dactylitis, pitting nails, or family history of psoriasis as well. If the patient do not fall into any category or fall more than one category, we put into undifferentiated arthritis. This figure will show you the frequency of each JA subtype in each region around the world. You can see that in Western countries, the oligoarthritis and rheumatoid factor negative polyarthritis are more common compared with the Southeast Asia. Systemic JA and ERA are more common. So the case 1 that I would like to share with you, a 3-year-old girl who presents with fever and joint pain for 7 months. She presents with high-grade fever, rash on her trunk, lymphadenopathies. And at that time, she was diagnosed with incomplete Kawasaki. And she would receive IVIG 2 grams per kilo for 2 courses. The fever went down, but it returned again. Then prednisolone 2 milligrams per kilo per day was given for a short period. She felt better at that time, but after discontinuation of the steroid, the fever, joint pain, and rash returned again. On her physical examination, she had mild pallor along with high-grade fever, tachycardia, multiple lymphadenopathies, and my hepatomegaly. She also had arthritis on both knees and right ankles, as shown in the pictures, and also had rash with no itching, and the rash usually went away with the fever, as shown in the pictures. And her CBC had mild anemia with the lymphocytosis, with neutrophil predominate and thrombocytosis. She also had increased the ESR, but other labs are normal. At this point, do you think what is the most likely diagnosis? Refractory Kawasaki disease? Or she has systemic JA? According to ILA criteria, the patient who have arthritis with a fever more than 2 weeks, and this 2 weeks of fever, they require 3 days of continent fevers, plus one of the following below: evanescent rash, generalized lymphadenopathy, enlargement of liver or spleen, and serositis. If the patient falls into this category, they call systemic JA. So here is the typical fever pattern that we call continent fever. You can see that the single rise of fever to around 39 degrees, and it went down. The patients will get quite very sick when the fever went up, but when the fever went down, they quite get very well. And the fever came along with the rash and came along with the arthritis as well. So if the patient had rash, the rash usually comes and goes with the fever. It's discrete, erythematous macule in size and salmon pink color. You can see this color, and commonly in trunk and upper extremity. And when the rash goes away, is leave no residue. When you apply pressure on the skin, the rash will go up. It's called Kerner phenomenon, and you can see in this point. The CBC will show marked leukocytosis with neutrophilia and high inflammatory markers with thrombocytosis and high ferritin level with anemia and inflammations. So the tips and learning point of this case. We should know what is the difference between systemic JA and Kawasaki disease. The two diseases is quite similar in clinical manifestations. But the quotidian fever is quite typical in systemic JA more than Kawasaki. And also if the patient has salmon rash, come and goes along with the fever. And if the patient has persistent arthritis, you would think about systemic JA more than Kawasaki disease. But if the patients have coronary aneurysms, had polyungual peeling and edema of hand and feet, and all patients have a good response to IVIG, that's one you should think about Kawasaki disease. Whereas the systemic JA, we have good response to steroid, not IVIG. So case 2, a 6-year-old boy who presents with a joint pain for 6 months. So this boy had joint pain in multiple sites, wax and veins. The pain usually occurred during the nighttime. No morning stiffness. He also had fever off and on along with joint pain and no weight loss. His CBC showed anemia and thrombocytosis and increased inflammatory markers with the iron deficiency anemia and ASO also negative. 4 days before admissions, he developed left knee pain and refused to walk because of the pain. He was treated with ibuprofen, and at that time, it's like a little bit better, and he started moving his leg again. But however, finally, he still refused to walk and developed left wrist pain. His CBC showed that the hematocrit was dropped to 24%, and the white blood cell count had lymphocyte predominate. So this picture is showing the arthritis that he had joint involvement. His mild swelling, limit range of motions, and he usually had increased the ESI and CRP as well because of the drop of the hematocrit quite rapidly. So we think that it's probably not the JA. So we suspect didn't he have malignancy? So we saw the peripheral blood smear and we saw some lymphoblasts. Finally, the bone marrow aspiration was performed with this boy and it showed acute lymphoblastic leukemia. So the MSK involvement in leukemia can range between 7 to 62%, depending on the literature. Patient can come with a limb pain around 40%, following by bone pain, joint pain, or limping. The MSK involvement was far more frequent in acute lymphoblastic leukemia compared with the acute myeloblastic leukemia. Previous study tried to compare between the leukemia with MSK involvement and leukemia without MSK involvement. So in around 1,000 of childhood leukemia, they found around 8% that having MSK involvement. And among this group, 95% had joint pain and 33% had bone pain. Among patients with joint pain, around 85% had arthritis and 14% had arthralgia. And the most common joint pattern involvement is polyarticular, followed by oligoarticular and monoarticular. And the joint involvement is usually large joint, ankles, knees, and elbows. And around 82% also had radiologic abnormalities. 1/3 of these studies, they found a misdiagnosis, and half of them diagnosed with the JA. So the patients who were diagnosed also had longer duration from onset of disease to diagnose with leukemia, which is around 60 days compared with the correct diagnosis with 30 days. So if they compare the leukemia patient with MSK involvement, this group of patients usually had higher hemoglobin level and platelet count, and lower white blood cell count and peripheral blood count compared with the leukemia patient without MSK involvement. Also, patients with MSK involvement, 17% have absence of peripheral blood cells, whereas the other group is only 10%. And median LDH was slightly lower in MSK involvement. Did you see this? So that's why it's quite difficult to diagnose patients who present with the MSK involvement. So in this study, they classify patients into 3 groups. The one is ALL, non-systemic JA, and systemic JA. As we know, the systemic JA is quite similar to the ALL, and it's very difficult to differentiate. So you have to know that what is the difference between 2 groups of disease. The ALL patient usually have low hemoglobin level, low platelet count, and low white blood cell count compared to systemic JA. And the neutrophil count usually higher in systemic JA, whereas the leukemia usually have lymphocyte predominate. And the median LDH usually be higher in ALL compared to systemic JA and non-systemic JA. But uric acid are not different much among 3 groups. So the tips and learning points of this case. If the patient presents with the morning stiffness or morning pain, it could be JA, mild malignancy. But if patient presents with the night pain, and especially the pain wake him up at night or night awakening pain, you should think about malignancy first. Malignancy usually has severe pain, not respond to NSAIDs, or only partial response to NSAIDs. In some patients, they have no sign of inflammation at all because it's own pain. If you see from the CBC, the malignancy patient, we have leukopenia, lymphocyte predominate, and thrombocytopenia. And this patient usually looks sick compared to the JA. So the last case is case 3, a 2-year-old girl that presented with a limping for 6 weeks. So this girl complained of right leg pain and refused to walk. And a week later, she had high-grade fever for 3 days. She took ibuprofen and fever and pain was slightly better, but still refused to walk for no reasons. So her CBC showed anemia, leukocytosis with neutrophil predominate, increased CRP, but hemoculture no growth. A week after that, the pain was worsening. She was admitted at the hospital nearby. She was treated with ceftriaxone and hydrocortisone, and she markedly improved. Fever has gone, and she started to walk again. But a week after that, her pain returned, and she could not walk. And at that time, I stopped all the medications and did the blood test MMI again. Her blood test at our hospital is quite nearly normal. Hemoculture still no growth. CBC did not show anything. She had iron deficiency anemia, that's all. But the MRI is quite interesting. She had myasthenitis, right side more than left side. She also had enthesitis. She had sarcoileitis and also have myositis in many muscles. So at that time, the radiologist suggests about the ERA. Because the enthesitis-related arthritis, patient can have arthritis, enthesitis, and sarcoileitis as this group. And patients can have HLA-B27 positive family history of HLA-B27 and telluritis. And patients usually be male, older than 6 years old. This girl did not have HLA-B27 positive. She did not have family history of HLA-B27. She had only arthritis, enthesitis, and sarcoileitis. So the ERA manifestations, 1/3, you can see the patient can come with the sarcoileitis, hip arthritis, and enthesitis. And when you follow up patients, it can increase to 60%. But if you see the demographic data of ERA, the age at onset is around 10 years and mostly male predominance. which is quite weird. Like this case is a girl and 2 years old girl. So I think it's unlikely to be ERA in my opinion. I'm thinking about infective sarcoiditis, which occur in around 1.5% of all joint infections. And the Staph aureus is the most common organism in this disease. However, around 50% of patients, they cannot find any organism in hemoculture, especially in younger children, because they think that it might be infected by Shigella kincaid. This kind of germ usually difficult to grow in culture media, often poor either from bone joint fluid or blood. And there are two main clinical forms of infective sarcoiditis: in adolescent, young adult, and in infantile, than 48 months. The patient usually present with limping and buttock pain without fever and early of the disease. And it's quite difficult to diagnose, especially in young children like this case, who cannot explain symptoms, and they will present with refusal to walk or bear weight. The patient can have no fever or low-grade fever with mild symptoms, with general well conditions. This is the MRI of these patients. At diagnosis, you can see that the inflammation is around here. And at 1 month after cephalexin treatment, it's slightly better. And at 3 months, it's nearly normal. So we did not treat patient with steroid. We treat only with antibiotics, and she seemed to be better. She can run and she can walk. So and at that time, we think about Shigella kincaid arthritis, which is usually affect previous healthy children aged less than 4 years. If it happened in older children and adults, those populations usually have other underlying conditions. Shigella kincaid arthritis usually affect the large joint, include knee, ankle, and hip joint over 80% of cases. However, it can found in other joints as well. For example, the sarcoidiac joint in this case, like this case. Because of my clinical presentation of Shigella kincaid, when infected hip joint, some people might be misdiagnosed as transient synovitis of hip. So the tips and learning point in this case: the ERA usually affect male patients aged older than 60 years. So which is quite different in girl and aged around 2 years, like our case, so it's unlikely. Number 2, the infections cause more severe inflammation than autoimmune disease. Like you can see the inflammation of the muscle around sarcoidiac joint in this case in the MRI, compared with the ERA that affect only the joint. And most ERA patients do not present with high-grade fever. And if patient present with a high-grade fever with buttock pain, thinking of infection first. So the take-home message of my talk today: infections and malignancy should be excluded before JA diagnosis, as you see in our case. If patients present with atypical JA manifestation, please consider other disease. So if the patient presents with a night pain and moderate to severe anemia, thinking of malignancy first. And if you treat patient with the first conditions and it results in a worsening or recurrence, please seek another disease. So sometimes things that look alike are different. Hope that you enjoy my talk. Thank you for your attention.